So the first case is a 72-year-old male. And he was suspected to have right side. He had right side pleural effusion and was suspected to have small cell carcinoma. So the patient has never been biopsically confirmed because all his biopsy specimen is a little bit tiny. Here is the pleural effusion specimen. So we do see some larger cells, which a little bit too big for a small cell carcinoma. The chromatin pattern is also non-neuroendocrine carcinoma pattern. So again, these could be reactive, but it also could be non-small cell carcinoma. Here, this cluster is more likely to be small cell. The chromatin pattern is more granular, finely granular. So again, the specimen, the lesional cell is not, it's very scant. So it is very difficult to make interpretation whether these small cell or non-small cell. So for the cell block preparation, again, because of scant lesional cells, we don't see a lot of cellular, like a positive cellular component over here. And I think this has to be examined with a more detail. So for this cluster, the chromatin pattern does have a very smudged chromatin pattern. However, the arrangement, we didn't see like a good molding. The cytoplasm seems to be quite plenty. There's a one tiny, like a lesional cell cluster over here, which is positive for TTF1. But the synaptophysin, I think this is very difficult to call this positive. So I think there is a non-small cell carcinoma component over here. And there were very, very scattered cells, which seems to be positive for neuroendocrine marker strongly, mostly in single cells. But by morphology, because it is very difficult to appreciate the cytomorphological feature of these cells. And these are just like chromogen stuck inside. So there were only very scattered cells, seems to be positive for neuroendocrine marker, but the cytoplasm seems to be bubbly. This is very weird looking. So I'm not very sure if we can confidently call this small cell carcinoma. So please, Baorong, please check with Dr. Gao again. I think it's better for us to be more conservative. Better not to call it small cell because I think they are non-small cell carcinoma components. So here is the TTF1. TTF1 also show a few individual cells, but these, because we don't have good morphology, these could be those synaptophysin positive cells. So these could be the small cell component, but again, I think these clusters, it is very difficult for us to just call it small cell carcinoma. So the specimen is very difficult to make diagnosis. It's more difficult than the usual small cell carcinoma, since the small cell carcinoma usually have high proliferation. So usually you will see more than one single cell, just a cluster of cells instead of one single cell. The second specimen is also from the pleura effusion. The patient had a past history of urothelial carcinoma, high-grade urothelial carcinoma. So this is the specimen is show a lot of inflammation, and they were scattered very atypical cells hiding in the background. So again, the specimen is very difficult to screen, but I think you can appreciate that these prominent nucleoli cells and these with multinucleation and prominent nucleoli, and this one as well, very irregular nuclear contour. So these are definitely some positive cells. So the patient do have a cell block. So these large atypical cells are positive for GATA3. There were some background lymphocytes show cross reaction with the GATA3, but you can definitely appreciate that the size of the nucleus is strikingly enlarged. So these are definitely positive cells. So the case is, this is the second case that we see this week for the metastatic urothelial carcinoma, but this one looks very different from the other with very scant cellularity. So back to the urine specimen, we do have two urine specimens. So for high-grade urothelial carcinoma, in the bladder, usually we will have a lot of tumor cell shedding inside the urine specimen, and a lot of them can show marked degenerative change. And but our diagnostic criteria is based on well-preserved cells, still have good nuclear contour, and sometimes with hypochromasia, especially in the highly degenerated specimen, and the high NC ratio. So these are definitely positive for high-grade urothelial carcinoma, and it is very common to see individual cell karyoresis, necrosis in the background. So usually the specimen looks pretty dirty. So this is positive for high-grade UC. A different patient, the urine cytology specimen, the patient do have a high-grade urothelial carcinoma history. So this specimen, the cell is more well preserved. So you start to see hyperchromasia and also the coarse chromatin pattern because the cell is well preserved. And again, high NC ratio and enlarged nuclear size is very important for the diagnosis. So this specimen is also positive for high-grade urothelial carcinoma, but the chromatin pattern is more hyperchromatic and with coarse chromatin. So rarely urine cytology specimen, we will encounter a situation that we see a lot of squamous cells with keratinization instead of the urothelial cell without flank keratinization. And whenever we see the specimen like this with squamous cell, but definitely some atypia, we need to first confirm if the specimen is from a male or from a female. So this specimen is from a male. It's not a female. If it's from a female, there is a possibility that these cells are actually shading from the genital tract, such as cervix or vagina or vulva. So it is important to let the urologist know or the kidney, like a nephrologist know that the patient might need to refer to GYN for cervical cancer screening. But this is from a male, so this is a little bit unusual. So in this specimen, we do see mature keratinized squamous cells, and a lot of them show enlarged nuclear size with a little bit hyperchromasia. Some even demonstrate a coelocytic change. And the number of these atypical cells are plenty. So it is likely the patient had the condylomatous lesion at the either meatus of the urethra or the it's rarely inside the urethra, but or on the on the genitalia, on the penis or something like that. The other thing is that uh, primary penis, there was also squamous cell carcinoma, but because this specimen, we don't have a lot of high NC ratio cells. So we need to address that there's a possibility of a condylomatous lesion, probably at the meatus of the urethra of this elder male patient. So it is, I actually haven't seen a urine specimen with these many typical squamous cell from an elder male patient. Usually they would just like a 3 or 4. But this one is like almost entire specimen are composed of these very atypical, like a low CO-like. Some even showing a little bit suspicious for high CO pattern. So we need to address that for this male patient. And there were also occasions that you will see high-grade urothelial carcinoma with squamous differentiation, but usually you will find definitely high-grade urothelial cell in the background as well as the dirty necrotic pattern. So this is a pancreas US guided biopsy. So our endoscopists discussed with her, so we're starting to change the way that we do the cytology specimen for US. Try to reduce the slide number and just try to start to apply the liquid-based cytology. So we don't need to screen so many slides. They don't need to send us so many slides as well. And with the initial, I think this is the second week, and I think the performance is pretty good. For this specimen, it is very unusual that we see a lot of squamous, benign squamous cells. When you see the benign squamous cell, you need to check that if this aspiration is actually from the esophagus. Why are there so many squamous cells? This is from the liquid cytology specimen. So it is impossible that because they didn't use the glove and just touched the slides, because all the specimens are from the liquid. It's not from the slide. So these must be coming from the sand specimen. But these the specimen is from stomach, and they sample the tail of the pancreas. So probably they scrap some squamous cell from the esophagus. I don't know. But anyway, we do have good visualization of high-grade malignant cells, and some with intracytoplasmic like mucin. Some of the cells show a little bit like spindly, but the nuclear feature, we again can see the vesicular chromatin and prominent nucleoli, and with the mucin. So overall, it looks like adenocarcinoma. Could it be an adenosquamous cell carcinoma? I think because we don't have very good visualization of definite squamous cells, so this time I think we still call this adenocarcinoma. So I think the preparation is pretty good. So again, this is the direct smear. So like the ultrasonal guided FNA, now we do 2 direct smear and 1 liquid-based cytology. So this one you can definitely see the very abrupt mucin vacuole in these highly atypical glandular clusters. So this is positive for adenocarcinoma. So now it's easier for us to just reduce slides to 3, and we don't need to report it for each pass. And they think it is okay because they have more experience now. So the next specimen is from the pleura effusion. The patient had lung cancer history. So this is the recurrence of primary lung adenocarcinoma, and most of the cells are starting to form these poorly differentiated single cells. And pay attention to the size of the nucleus. So this is the lymphocyte, and you can see it is like almost 20 times bigger than the lymphocyte. So these are very large cells and definitely malignant. So this is positive for recurrence of primary lung adenocarcinoma. So again, this is from a patient with primary lung adenocarcinoma. And the specimen, I would say, is more difficult to interpret than the other one. First thing is that the lesional cell, atypical cell, are very scant. And it definitely shows some reactive type changes because you can see like double color in the cytoplasm. However, in a pleural effusion specimen, if you see large cell and with very abundant bubbly cytoplasm, it is almost always metastatic adenocarcinoma because for the usual mesothelioma, it won't form big bubble. So these cells, I'm not very sure. These could be just reactive. So in this specimen, the cell number, the typical cell is very scant. If we go to the cell block, yeah, I think this one definitely you should call it positive. So the patient is newly diagnosed. She was diagnosed last month in November, and she started to have treatment. So in last month, her pleural effusion showed a lot of adenocarcinoma, which is positive for TTF1. So I think this is just a treatment effect, and in a very short time, so you see some unusual morphology, but these are positive for adenocarcinoma. So I think this is just in the period of treatment. Usually we won't get this type of specimen, but sometimes they will just keep sending to us. And yeah, you compare with the prior specimen, which just in 1 month ago, and yeah, this is positive, but it's showed striking treatment effect. Again, this is a lung carcinoma patient. It is a new patient. So we see these definitely malignant cell in glandular cluster. The cell is pretty high grade with large cells. And we do TTF1 for this new patient on the cell block preparation. In the cell block, the tumor cell is not so many, but still we can demonstrate these very large tumor cells are strongly positive for TTF1. So let's move to some fine needle aspiration. The first specimen is from the breast. So on low power, we see hypercellularity. On high power, this cell just looks like the high-grade adeno that we see in the pleural effusion specimen. So when we receive the aspiration, looks like this. This is very easy. This is positive for carcinoma. And because of this very cohesive pattern, it is invasive ductal carcinoma. And we don't see a lot of myoepithelial cell in the background. But because of the current treatment guideline, with this type of diagnosis, you need to do the ERPR HER2 to check the hormone and the HER2 status. So usually we won't get this type of specimen. At the beginning of my practice, I think we received this type of specimen probably more than 1,000 per year, but nowadays probably just a couple hundred because everything's shift to the biopsy. So really we would receive these like a flankly malignant carcinoma, we will usually receive some papillary lesion, and it's more difficult to interpret. So the second specimen is from thyroid. The cell is not, the specimen is not very cellular. In the background, it's kind of clean without a lot of colloid. Here we have a monolayer sheet. The nucleus seems to be slightly enlarged and with quite irregular nuclear contour and some grooving and some powdery chromatin, ground glass chromatin. So this one looks like a papillary thyroid carcinoma. So in the liquid-based specimen, we don't have a lot of cells. We have a bit more in the direct smear. So this one is more convincing that we have these enlarged follicular cells with some irregularity and ground glass chromatin and overlapping as well. It is very difficult to find a single nuclear inclusion in this specimen, but because of these overall morphologic pattern, I think we can still call these papillary thyroid carcinoma. And please pay attention to so-called disorganization or loss of polarity pattern. If you draw a line along the axial of the nucleus, you can see they are all intercrossed with each other with a very haphazard pattern. So this is disorganization, and these type of disorganization won't present in benign reactive follicular cell. Here is a vague like nuclear inclusion, but because of these the membrane of the inclusion is not very clear, it is just a vague one. But I think overall, because of the cell morphology, we can still call these positive for PTC. Again, this is a vague one because there's not a very clear membrane of this inclusion, but the overall nuclear pattern is consistent with papillary thyroid carcinoma. So move to the parotid gland. We have a couple polymorphic adenoma. So this one, we only have very tight three-dimensional cluster, but at the edges, you can still appreciate these are fibrillary chondromyxoid matrix, and you can see some spindling myoepithelial cell intermingle within the matrix. We always like to see the Ginza type stain, which highlight the extracellular matrix. So here again, you can see these very typical fibrillary matrix, along with some oval spindle myoepithelial cells. Right next to it, there seems to be a cluster of ductal cells. So you have all three components: stroma, myoepithelial cell, and ductal cell. So this is a polymorphic adenoma. The next specimen is also similar, with more cell. Seems to have more myoepithelial component, but also we do have some stroma over here as well. The direct smear, the cellularity is more scant, but still we can appreciate that these chondromyxoid matrix with a very indistinct edges seems to be like a feathering, and there are some spindle cell nucleus in the center. So this is also a polymorphic adenoma. So there were two more uncommon salivary gland aspiration. So this one is from a parotid of an elder female. The lesion is around 1 centimeter. So in this specimen, we have almost exclusively oncocytic cell, oncocytes. the background is really clean. You didn't see any cystic or degenerative debris in the background. And the cells seems to be bland looking with small tight cluster, uh, like clustering with each other. And we also see some vasculature, like and the cell cluster is like sticking around these vascular like a structure, such as this. It looks like a bunch of grapes, pattern. So with oncoCT specimen plain looking, but the architecture arrangement showing this bunch of grapes pattern, it is most likely a benign oncocytoma / nodular oncoCT hyperplasia. And because this is a very cellular specimen, let's do a cell block to check if there's any like tissues that we can appreciate the structure more easily. The differential diagnosis of this type of aspiration is either benign, suggests oncocytoma, versus should we call it SUMP with oncocytic features. For cases that I would like to call SUMP with oncocytic feature, usually won't show these very organized architectural pattern in the small bowel. Usually there will be more like a diffuse larger sheets of the cells. And we do have a case that, a few cases that we see it could be an oncoCT mucal F, and then we diagnose some oncoCT, and it turned out to be oncoCT mucal F. So these are the major differential diagnoses. So we here we usually don't call every cases with oncocytic cells as SUMP, and we will try to just lower, like a downgrade some diagnosis into benign oncocytoma if the architectural pattern fits. So we would do a cell block to confirm that. So the next specimen is also from salivary gland, but they say this is also from a parotid. I checked the sonographic finding, and it seems to be really inside the parotid gland, but what we only see is these keratin debris with a nuclear cells and some nucleated cells, which is also kind of bland looking. So we could think about epidermolysis, but it seems to be very deep-seated, so it is kind of confusing. For this type of specimen, because it is sampled from the parotid gland, so we still want to call this based on the Milan system. So for the Milan system, I think this is the good occasion for AUS, because for AUS, usually means you are debating between a neoplastic versus a non-neoplastic lesion, or a low-grade lesion with metaplastic change or something like that. The patient is elder female. She doesn't has like a smoking history. So it is also not very likely that it is a metastatic squamous cell carcinoma from the other head and neck organ. So this one just very weird. So we call it AUS because it is nothing more than we can comment on this specimen. Yeah. So this is kind of unusual. So we have a pretty uncommon specimen from a 43-year-old male sampling from the acetabulum. I haven't checked. The clinical note is not very clear about the size of the lesion. So the first sign that we see is that we find quite some this bluish matrix type material in the background. A couple weeks ago, we have a case showing definitely chondroid component. But in this one, we do have these like a chondromyxoid type of matrix, but the matrix seems to be more fibrillary, not as rigid as a chondroid component should be. The cell inside doesn't show the lacuna, like a space lacuna component. So these are just like oval shaped cells. So these looks very strange. So this is what we got. And it is very like a thick. So we go to direct smear, which we can appreciate more like a fibrillary type, more like a loose type of matrix. So this does not looks like a true chondroid matrix. For the cells, you start to see a little bit more cytoplasm, some with a little bit bubble. So these looks like physalliferous cells. So the specimen is actually, I think this should be a chordoma or a notochord remnant. So we need to check with the size of the lesion. So this is, I would say the cytomorphology is very typical for chordoma with these type of matrix, and we realize it's from the axial bone. So it should be a chordoma, but we need to check with the size of the lesion. So finally, we have one pap smear. The patient had the past history of endometrial cancer, and she already received complete surgery. So the patient already doesn't have a uterine cervix. So in this specimen, we see quite some atypical cells. And then we realize that this cell is definitely squamous, not glandular, because of these very rigid cytoplasm and very hyperchromatic, like chromatin pattern. So these are atypical squamous cell component, and some already show increased NC ratio, and most of them looks very hyperchromatic. So we have some definitely low CO type, like atypical cells such as this one, but it's getting a little bit more cells with increased NC ratio, such as these guys, and the amount of a typical cell is just too many. So we should call these CIN2, instead of just low CO. So this is qualified for CIN2. Like we have more like a high CO type cells over here. And this is not from the cervix, this is from vulva. The patient has been regularly followed in our outpatient department, and she has been called low CO of the vulva with smear with biopsy for multiple times, but she never received the Y excision. So I think the lesion already progressed to high CO, to CIN2. So for this specimen, we would call it CIN2 instead of CIN1 because it's just too many of them, and it's exceeding the pattern of the low CO already. So we will call this CIN2, and to let the clinician proceed for the excision. Otherwise, it could develop into an invasive squamous cell carcinoma. Okay, so this is for today. Thank you.
刚刚那个不对比较 VN 图吗？
对。